Hello everyone, my name is Dr. Vaibhav Garg. I am a second semester medicine resident at PGI Chandigarh. Welcome back to my channel. It has been quite some time I have made any kind of video on YouTube. I was figuring out what kind of videos I should make, and I'm thinking about starting a new series called Case Files where I can discuss some of the cases which I am seeing in my emergency duties and various specialty postings, what kind of presentation they have, what diagnosis are we doing, and the broad treatment modalities which are being done. And I will try to make them short and crisp and not take much time of your day as well as mine, because we all know time is um is necessity during the residency days. And the main aim of starting this would be to keep all of you as well as myself engaged in some kind of activities related to academics, because the hectic physical hours of the duty timing take a toll on all of us. So I think this kind of video would be helpful for all the residents as well as interns who are currently doing their duties and are looking for some source of academic while some sorts of academic discussion from my end. So in today's case, I am thinking about taking up a case from endocrinology where we'll be discussing about a young patient with pheochromocytoma. I will try to keep all the details modified to maintain the confidentiality, and the purpose of this video will be only for educational purpose. So here we begin. So today we are going to discuss a very rare but important endocrine case. This is a case of a young female who presented to OPD with history of 1 year complaints of intermittent right upper abdominal pain. But for the past 3-4 months, she had also started experiencing on and off palpitations and headache. In the past, she had history of high blood pressure recordings, but she was not on any kind of regular medications and took the antihypertensives occasionally. Notably, there was no history of sweating spells, visual disturbances, weight gain, or features of Cushing syndrome. Her family history was significant, as her elder sister had undergone surgery for a paraganglioma. Upon evaluation, her vitals were normal. There was no pallor edema or any kind of neurocutaneous markers. She was planned for investigations, and initial ultrasound revealed a 5 into 5.6 centimeter well-defined heterogeneous mass which was abutting the upper pole of the right kidney. That is, a suprarenal mass was found. She was evaluated biochemically in the lines of an adrenal tumor, which revealed a very high plasma normetanephrine levels of 3270 nanogram per liter, the normal value for which should be less than 135, while the metanephrine and 3-MT were within normal limits. Other hormonal workup was also done, including thyroid, cortisol, and ACTH, but all were within the normal limits. ECG and echo were also normal. In a chronically hypertensive patient, we would expect left ventricular hypertrophy, but that was not seen in this case. Fundus examination also did not reveal any kind of changes of hypertensive retinopathy or changes suggestive of retinal angiomas. Ultrasound neck was also planned, which showed a 4 into 3 mm solid hypoechoic well-defined smooth margin lesion in the right lobe of thyroid. For further imaging of the adrenal gland, a CT abdomen was performed, which showed a 6 to 7 centimeter heterogeneous enhancing lesion in the right adrenal. To exactly define the lesion, its avidity, and whether there was any spread or any other source of catecholamine release in the body, a PET CT was performed, but it was suggestive of pheochromocytoma, and well-defined heterogeneous enhancing soft tissue mass was seen with central hyperdensity suggestive of necrosis. Based on the symptoms, the biochemical results, the imaging, and the family history, we made a diagnosis of right adrenal pheochromocytoma, likely familial paraganglioma syndrome, PPGL. In the management of such a case, we prepared the patient with alpha blockade with prazosin followed by beta blockade with metoprolol, because adequate preoperative preparation is crucial for prevention of hypertensive crisis during the surgery. The laparoscopic adrenalectomy of the right adrenal gland was performed by the surgery team. Procedure was uneventful, intraoperative BP pressure was stable, and she was hemodynamically stable at discharge and did not require any antihypertensives. So the learning points from this case is that pheochromocytoma, catecholamine secreting tumor, often presents with triad of headache, palpitation, sweating, but in this case, our patient primarily experienced pain, abdominal palpitations, and occasional headache. If there is a family history of paraganglioma, that is a strong that strongly raises the suspicion of pheochromocytoma in such a case. And whenever a young patient presents with pheochromocytoma, biochemical confirmation with plasma urine metanephrine is mandated before surgery, and preoperative alpha blockade is life-saving. And beta blocker should be added only after alpha blockade. Familiar cases also require genetic testing and family screening. Now we'll be doing a short discussion on the topic pheochromocytoma. So the clinical suspicion of pheochromocytoma arises when there is a triad of symptoms which includes headache, sweating, and palpitations. And the dominant sign seen in such cases is hypertension, which could be paroxysmal or sustained. Catecholamine crisis can lead to heart failure, pulmonary edema, arrhythmia, and even intracranial bleeding. So in the diagnostic protocol, the first step which we have is biochemical testing and documentation of catecholamine excess, for which the preferred tests include plasma-free metanephrine, which is most sensitive and it is less affected by the stress, and 24-hour urinary fractionated metanephrine and catecholamine. We can use HPLC, LCMS, and ELISA for these tests. The protocol for this biochemical testing is that the patient should be supine more than or equal to 30 minutes before the plasma draw, and a value of more than 3 times the upper limit of normal is highly diagnostic. It is important to avoid confounders in such cases like stress or drugs like tricyclic antidepressants or sympathomimetics, levodopa, diuretics, alpha beta blocker before repeating the borderline tests. If there is a borderline test, you can consider to perform a clonidine suppression test in such cases. After a biochemical proof, the next step would be to perform imaging, in which the first line, as per the recommendations of the Endocrinology Society, is CT thorax, abdomen, and pelvis. For head and neck paraganglioma, metastatic disease, and children and pregnant females, we can consider using MRI. MIBG scintigraphy with iodine labeled iodine 123 and 131 labeled compound is useful for metastatic disease, especially if iodine 131 MIBG therapy is planned. Coming to PET CT, F18 FDG PET CT is best for metastatic or SDHB tumors, and F18 DOPA or gallium-68 dotatate PET for hereditary multifocal disease can be done. For genetic testing, it is recommended that all patients of pheochromocytoma should undergo genetic testing, and indications for genetic testing are young age, bilateral or multiple tumors, extra-adrenal tumors, metastatic disease, or family history. Coming to the preoperative management, alpha blockade is recommended using either non-selective or selective agent. Non-selective agents like phenoxybenzamine and selective agents like doxazocin or prazosin, which should be started 7 to 14 days before planning the surgery. And titration should be done. Preoperatively, volume expansion should be done with high salt and fluids to correct the chronic catecholamine-induced hypovolemia. And beta blockers should only be used after alpha blockade for treatment of tachyarrhythmias. Unopposed beta blockade should be avoided because that can land the patient up in a hypertensive crisis. The definitive treatment is the surgical treatment, in which laparoscopic adrenalectomy is the standard for most of the adrenal pheochromocytomas. But if the tumor is more than 6 centimeters, it is invasive, it is complex, then open surgery can also be considered. And in hereditary cases, to preserve adrenal gland, partial adrenalectomy is also advised. In the post-operative period, we have to monitor the BP and the RBS values because there is a sudden catecholamine withdrawal, so the patient is at risk for hypertension and hypoglycemia. And in long-term, annual lifelong biochemical testing is recommended. And it is important to note that recurrence of metastasis can even occur more than 10 years later. Special scenarios are in pregnant female where the adrenergic crisis can be triggered by HCG. So the safer surgery would be to do it in the second trimester by laparoscopy method. 5 to 10% cases could be metastatic disease, in which iodine 131 MIBG or yttrium 90 Dorotid would be recommended. Chemotherapy regimen would be according to Averbach protocol, which includes cyclophosphamide, vincristine, and carbazine. And the targeted therapies for pheochromocytoma under study are with sunitinib and temozolomide. So this was all for today's topic. I will try to come up with another topic, another case on next week or in upcoming week or two, and we'll have discussion on that disorder as well. Thank you.